I'm not going to try to turn you into oncologists or hematologists. I'm going to try to give you some things that are going to help you through the boards. And so in taking that approach, I decided to give my talks the subtitle, Searching for a Few Diamonds in the Dung. And we'll talk more about diamonds and dung. Now, this is just my opinion, my opinion about standardized testing. It's really about your ability to recognize the important testable concepts or factoids, the diamonds, when you're trying to study massive amounts of dung. Right? I mean, think about, you've done this already. You did USMLE 1, you did USMLE 2, and every time you've sat down for that, to get prepared for these exams, it just seems like such a daunting task. There's so much dung. So what you have to do is you have to learn to go through the material and recognize the things that you think are really important or really testable or just really quirky that some nerd like me is going to think might make a great board question. So, but that ability, that diamonds and dung ability doesn't really just apply to how you prepare for the tests. As you've taken every standardized test in your life, and good Lord knows, it's going to be a lot more, recertifications, all that kind of stuff, that the questions you're dealing with require that same ability to recognize the diamonds from the dung. Just think about it. All the questions that you're going to take on this board examination are going to be long. Well, not all, but for the majority of them, they're going to be long. They're going to be filled with a lot of information, some of it completely spurious. And what you have to do is pull out the critical data. Again, pull out the diamonds from those long, wordy, dung-filled case scenarios. Okay? All right. So, my goal today is to review the hematology and oncology content areas. We'll do oncology first and help you identify the diamonds and the dung from each content item. So the oncology outline is going to follow leukemia and lymphoma, the liquid tumors, the solid non-brain tumors, a very little bit about brain tumors, some things on survivorship, a couple of comments on not cancer, and then very briefly a comment or two on cancer warning signs. So let's talk about the liquid cancers. The way I'm going to do this is I'm going to start with each little subunit with a question or two, and you guys will do the polling, and then we're going to go back and we're going to dissect the question. So this question is a 3-year-old boy who presents with a 2-week history of lethargy and diffuse pain in his legs and arms. His physical exam reveals pallor, bruising, a 1-centimeter cervical node, and a palpable spleen. His labs show a hemoglobin of 6.1, a white count of 3.7, platelets of 33,000, and he also has a normal chest X-ray. So what is the diagnostic procedure or laboratory that's going to provide the most information? Okay. So go ahead and make your vote. Okay. I'm going to feel old here and just make a quick comment. What you're trying to do on picking diagnostic procedures in some kind of standardized test is you want to look for the Willie Sutton test. Does that make sense to anybody? Does anybody know who Willie Sutton was? Okay, Willie Sutton was the bank robber, right? They asked him, well, why do you rob banks? It's because where the money is. So you want to look for the Willie Sutton test, okay? So if we were to go back and look at this question, what diagnosis does this child have? This child has pancytopenia, right? All 3 cell lines are down. So in pancytopenia, what's the Willie Sutton test? Well, we've got to look at the bone marrow. So a bone marrow aspirate is the test of choice. Okay. Second question. And this is kind of the exception to the case-based kind of question that you'll usually get. But there are certain facts that are just plain old testable. And this question tests facts about leukemias in children. So which of the following statements regarding leukemia is not correct? It is the most common form of cancer in children. Peak incidence is 12 to 16. Most common form is ALL. More common in white than non-white children. There's an increased incidence of leukemia in children with Down syndrome. So which one's not correct? So you guys are doing very well. So leukemias are the most common form of cancer in children. It's always going to be acute leukemia, then lymphoma. Its peak incidence is in what I call toddlerhood. Yeah, the numbers you can see will be different, 2 to 5, 2 to 6, something like that. But in that transition from toddlers to the start of school. The most common form is ALL, followed by AML at it's about a 5-to-1 ratio. It is more common in white than non-white children. And in children with Down syndrome, there's both an increased incidence of ALL and AML. Now, for the bonus round out there, you can kind of jot down a note that we'll get back to. You can try to think of what is the one type of AML that is very common, relatively speaking, in children with Down syndrome. We can get to that in the bonus round. Okay, so let's talk a little bit use these two questions to do a little bit about leukemia as an overview. To diagnose leukemia, you almost always have to make a bone marrow aspirate or perform a bone marrow aspirate. So that's your Willie-Sutton test. As I mentioned, there are two types, acute lymphoid leukemia and acute myeloid leukemia. Chronic leukemias, for the most part, don't happen in children. CLL does not exist in children, and CML, at our hospital, the biggest cancer center in the U.S., we may see a case of CML once every 2 years. So ALL and AML are what we're talking about. ALL generally has a better prognosis, 80 to 90% survival for all comers. AML, if you've seen, is a very interesting disease, very hard to treat, and can show up with some of the strangest symptoms. If you've seen it, you'll remember it. It'll show up with skin and soft tissue infiltration, bright red gums on a patient with pancytopenia, very bizarre type presentations. You can't absolutely distinguish them by morphology on a smear. You may remember back from medical school we'd talk about hour rods. Things like hour rods are not always present, you're not good enough. I'm not good enough to find them. I like to show the aspirate. This is not something you'll have to look at, on a board exam likely, but I like to show it so that it can. If you do see something like this, you would know it, but also to help you kind of hang on to certain information about leukemia. So blasts are big. That's what distinguishes them. They have this high nuclear to cytoplasmic ratio. As you guys can see on either one of these projectors, it's pretty hard to find any cytoplasm around those big cells. They have some dispersed chromatin, and if you look really closely, you can see nucleoli. But when you make this diagnosis, what you see is monotony, okay? When you look at an aspirate of a child with leukemia, you just see the same thing over and over again, blasts and more blasts. Where you look at the aspirate for a healthy child, you're going to see cells at various levels of maturation. You're going to see cells of granulocyte origin. You're going to see a lot of different things going on. You won't have to do this, but I just love pathology, so I need to throw it in there. It'll maybe help you hold on to a couple facts about ALL and AML. In ALL, you can see these in AML, you can see these hour rods, and if you look at this slide, you'll see it about at, the 5 o'clock position. The ALL blasts tend to have a little more nucleus and a little less cytoplasm. Okay. Some more facts about ALL. It is the most common childhood cancer. Most ALL comes from cells that were on their way to grow up to be B lymphocytes, so it's called pre-B ALL. T-cell ALL does happen about 14% of the time. Mature B-cell, kind of the equivalent of a Burkitt's lymphoma, is very rare, occurring only about 1% of the time. Again, we talked about the epidemiology. The big peak is toddlerhood, smaller peak as they get older. Some signs and symptoms you might want to hang on to as, clues in a question. The 4 Ps, what the pathologists call it: pallor, pyrexia, petechiae, and pain. Fatigue, refusal to bear weight. Please, please, please always consider cancer as a potential diagnosis. Consider it in your differential for the refusal to bear weight. Really important both in your test taking and important to you as a clinician as well. Lymphadenopathy, organomegaly can be important. But remember, let's go back. I'm not going to flip back to it, but you can think back to that first question that we talked about, where we put up the information about the little boy with ALL. Let's talk about diamonds and dung for that question. We said that he had a 1 centimeter cervical node. Diamond or dung? Right, okay? You guys have been pediatricians long enough to know that, line up 10 toddlers, 9 of them are going to have cervical nodes of about 1 centimeter. So, lymphadenopathy is only important if it's big, probably greater than 2 centimeters in the neck, or in pathologic locations like supraclavicular. Supraclavicular is a place that you'll often see adenopathy in lymphomas, Hodgkin's and non-Hodgkin's. Lab work in acute lymphoid leukemia is really not always helpful, other than that you'll see leukocytosis, lots of white cells, and usually then you'll see peripheral blasts, or very few white cells, leukopenia, when the bone marrow is packed with blasts. You can see some abnormal elevations in uric acid or LDH. These are just markers of cell turnover, the phenomena that we refer to and you remember from rotating with us, tumor lysis. You need to know nothing about treatment. It's treated with a lot of chemotherapy in a lot of different phases, and an important element of that treatment is that we have to treat the central nervous system. We do that with intrathecal therapy. Overall, the prognosis is excellent. If you're older than 10, you need more treatment. It's a slightly worse prognosis. If you're less than a year, we call it infant ALL, and it is probably biologically a different disease. Historically, the Philadelphia chromosome has been something that has indicated a very poor prognosis, but with some of the drugs that target that tyrosine kinase, actually the outcomes are starting to be quite good. AML, again, about 5 times less common than AML. You may remember that there are different morphologic subtypes. This is probably a little bit low yield, but it is worth hanging on to just in the back of your head that there are 2 types of AML that are important. One is M3, or acute promyelocytic leukemia. These are children who present in horrible DIC and have about a 5% mortality in the first 14 days because of that. And this is a disease characterized by a particular translocation, 1517, which makes it sensitive to all trans-retinoic acid. M7 is what we call megakaryocytic AML, and it's associated with trisomy 21. Patients with trisomy 21 have I think about a 40-fold elevated risk of relative risk of getting M7 AML, but for them it's actually much more treatable. Signs and symptoms are similar to ALL. Again, you can see some funny presentations, soft tissue infiltration behind the orbit called an orbital scleroma. Treated differently, very intensive chemotherapy, and sometimes these patients go to transplant. The prognosis is not nearly as good as ALL. It's about a 50% overall survival. Better in M3 if you can get them through that first part of therapy, and better in Downs patients with M7. Okay. 4-year-old boy, new to your care, history of eczema, intermittent thrombocytopenia, and recurrent infections, presents with a history of weight loss, fever, night sweats, and severe constipation. His physical exam reveals multiple cervical nodes, and a CT shows up enormous abdominal mass. So which of the following is false? Okay, so patients who have underlying immunodeficiency are at increased risk of lymphoma. Okay, many people consider cancer just to be a failure of the immune system. So if you're immunodeficient, you've got a higher risk for cancer. B symptoms, okay, fever, weight loss, night sweats, those are all bad things, and they have a negative impact on your prognosis in Hodgkin's disease. It's important to know that lymphoma is not a surgical disease. Years ago, they even used to, surgery actually used to be part of the staging process with staging laparotomies. That's long gone. And it is also true that some lymphomas are driven by EBV infections. So a 7-year-old girl presents with a 6-week history of right submandibular lymphadenopathy. She's been treated with 2 courses of antibiotics without resolution, but is otherwise healthy. She's got a 4-centimeter node, okay, diamond or dung, diamond. PPD is 3 millimeters, and testing for cat scratch disease is negative. So why is her node a diamond, both clinically and for the question? It's big, and it's been there, okay? So we know that it's a diamond, okay? All right, now channel your inner Willie Sutton for me, please. Rob the bank, okay? What is your most valuable diagnostic test? A CBC, EBV titers, excisional biopsy of the lymph node, CT of the neck, measurement of ESR and CRP. I want this to be a perfect score. Okay, somebody said put in ESR and CRP just to irritate me, I bet. Okay. Who has diagnosed anything with an ESR or CRP? Please. Okay. The CBCs, yes, I probably would have ordered it, okay? EBV titers are interesting. CT of the neck, well, okay. That you probably might do that, but you're going to, you already know there's a node there. You might want to know if there are a few more nodes there. What's Willie Sutton going to order? He's going to take it out, okay? So when tumor is the rumor, tissue is the issue. Okay. Okay. All right. Okay. So lymphoma is always diagnosed from biopsy. It's in the adult world, it's often needle biopsies. In the children's world, we don't like that. We like to see the whole lymph node, and so that we can see the whole architecture. As far as you're concerned, there are only 2 types of lymphoma. There's Hodgkin's and non-Hodgkin's. Their incidence is similar in children. I can find you references that tell you one is more prevalent than the other. I can find you references that flip it around the other way. So we're going to say they're similar. Hodgkin's classically, though not always, is seen in older children. That is your teenager who has night sweats, who comes in, you see a supraclavicular node, and because Hodgkin's moves from nodal group to nodal group, you're going to get a chest x-ray, and there's a big mediastinal mass. Non-Hodgkin's patients, though not always, are often more acute and sicker. You can kind of relate your non-Hodgkin's patients to maybe a Burkitt's patient if you've seen one. Big mass, growing quickly, sick patient. So non-Hodgkin's, heterogeneous group of diseases. The one that I think is the one to kind of hang. I've always thought of learning as being something where you put a peg down and then you hang knowledge. So if you've seen a Burkitt's patient or a non-Hodgkin's patient, just try to hang some knowledge on that. So it's a rare disease. They'll present with fever, fatigue, lymphadenopathy, sometimes constipation with massive abdominal involvement. These are patients that can get in trouble with TLS, tumor lysis syndrome, or if the masses are up in the mediastinum, they can have severe vena cava syndrome. And, when you see it, you'll never forget it, intestinal perforation from one of these tumors, leading to kids being incredibly sick. The CBC can be normal. There can be elevations in uric acid or LDH, again, just from cell turnover. They're treated with chemotherapy. They're treated like leukemias in that you have to treat the CNS with spinal or intrathecal chemotherapy. And in kids, their prognosis is actually pretty good, though it varies some with stage. Hodgkin's, about the same incidence, many pathologic subtypes of which you need to know nothing, associated with EBV and immunodeficiency. B symptoms. It's a classic kind of medicine pimping question, but I so like it that I just included it. It can present with itching and alcohol-induced pain. Hopefully that's not something that we see with our patients too much, but it is kind of a classic medicine question. But what is interesting is they can also present with strange paraneoplastic syndromes, including ITP or autoimmune hemolytic anemia, AIHA. Often normal, ESR and CRP can be elevated. Or again, you don't diagnose anything with those, but you can use them as a real poor man's marker of disease response. Treated with chemotherapy and radiation, and generally have an excellent prognosis. I like pictures, and they're in here, not some of them in the next 2.5 hours that we're going to be together are going to be for you to know for the boards. Some of them are going to be to keep you awake, and some of them are going to be just to maybe help, by seeing a crazy picture, help you remember something about the disease that we're talking about. And so I put this one in kind of in the crazy picture to help you remember something about non-Hodgkin's lymphoma, and that these can be massive tumors that can, this is your tumor right over here, and this massive tumor can lead to all sorts of problems, including a risk of perforation. Again, I put this one in here, not that I necessarily expect to see it on your boards, but it is a great picture, so its possibility of being there, does exist. This is, from med school, the classic owl eye appearance of Hodgkin's disease and the Reed-Sternberg cell. Okay. Solid tumors. If I get too excited, I'm sorry. It's what I do. I take care of solid tumors. But and there'll probably be one or two questions that are maybe a little bit of a stretch. But what I want you to do for solid tumors is I want you to learn to match the story with the tumor. Okay? So that when you read that long question, you'll say, that story sounds familiar. That's the patient. Oh, the patient with one limb longer than the other and a really big tongue, I know he has this. Oh, the former premature infant. It's going to be a question about this kind of tumor. Okay. So we have a 3-year-old girl who presents for evaluation of fussiness, low-grade fever, diffuse bone pain. And on physical exam, you palpate a non-tender mass deep in the right periumbilical area and note mild purple discoloration of the eyelids. Which is the most likely diagnosis? Wilms tumor, Hirschsprung disease, intussusception, neuroblastoma, hepatoblastoma. Okay. So, again, think about that question. What are some of the diamonds? Look, I'm talking about oncology, right? So, it's going to be an oncology answer. But what are some of the things that tell you it's going to be an oncology answer? Bone pain, okay? Bone pain, diffuse bone pain is like a code word for cancer, okay? So this is a little bit of a tougher one, and the correct answer here is neuroblastoma. And so, I'll reinforce this, but what I want you to think about with neuroblastoma is this is the ill-appearing child with a solid tumor. Okay, these children come into clinic, they look sick. They have fever, they hurt, they can have this blue-purple discoloration, around the eyelids, and that's all, from infiltration of the tumor everywhere, in the bones, in the marrow, in the bones around the orbit. And so that's the story that goes with neuroblastoma. Okay. 2-year-old boy presents after his grandmother palpates a mass. My impression from exams I've taken is it's always the grandmother, okay? Okay. Mass while bathing him. On physical exam, blood pressure is 120/75. Diamond or dung, large firm mass in the right upper quadrant, gigantic diamond, okay, microcephaly, macroglossia, right leg 2 centimeters longer than the left, and a UA shows microscopic hematuria, okay? All right, I don't want anyone to miss this question, okay? All right. And okay. You guys are killing me. I think somebody's out there just dogging me. We're going backwards now on this. Okay. All right. Let's go through this. The blood pressure is high. Might be a kidney. Okay. Mass in the right upper quadrant. Okay. Microcephaly and macroglossia. Okay. So this child just doesn't look quite right. Is to use the term maybe syndromic, right? Big tongue, okay? Right leg longer than the left, okay? What are we thinking? That's Hemi hypertrophy possibly, right? Hemi hypertrophy can be a feature of Beckwith-Wiedemann syndrome. So what I want you to get out of this question is that Wilms tumor happens in children who are generally well-appearing. It happens at an increased incidence in children with syndromes. The one to keep in mind the most is Beckwith-Wiedemann syndrome. Okay? Think about what Beckwith-Wiedemann syndrome means. And then think about some of the signs and symptoms that you can see in patients who have a Wilms tumor. Hematuria, elevated blood pressure, all those things. Okay? So there were a lot of clues packed into that question. And the reason is I want you to go back. In preparing for boards, I'll be honest, I always struggled studying. I just did not enjoy reading, but I always liked to do questions. It was a way to kind of, it was easier studying for me. So if you go back and you look at that question, maybe it'll be really easy for you. But it's not just getting the right answer in the question. It's thinking about what led you to the right answer. So when you go back and look at that question, hopefully you'll remember all those things that led you to the right answer. Now this question, I'm not going to give you the time to do the audience response. This is the one you have to forgive me for. This is the question that my little niche in the big Baylor world is that I take care of children with liver tumors. Okay, so this is a former 26-week preemie with a big mass. Okay, and so we're just going to do this question together. As a former preemie, the patient has an increased risk of hepatoblastoma. Absolutely, positively, yes. A 26-week preemie or a child under 15 grams has somewhere between a 10 and 100-fold risk of hepatoblastoma. And you may say, why the heck, do I care about hepatoblastoma? There are like 150 cases in the United States each year. Well, if you plot the incidence of hepatoblastoma and the incidence of survival for 26-week preemies on a graph together, they're going to go like this. As survival of 26 weeks preemies keeps going up, the incidence of hepatoblastoma keeps going up. And so it's a tumor that, clinically I would appeal to you that you need to know about because you're going to take care of former preemies. Interestingly, children with Beckwith-Wiedemann are also at risk for hepatoblastoma. We always think of BWS with Wilms tumor. But they have, I follow those patients in clinic with ultrasounds every 3 months to look for their Wilms tumor. And we also check their serum alpha-fetoprotein because C is also true. In hepatoblastoma, serum AFP will almost always be elevated. We're not talking a little bit. We're talking 10,000, 100,000, 1 million. Now, in newborns, it's a little tricky, because an AFP's values aren't well established. And so in a newborn, you might have an AFP of 80,000. So it's the number, it's not quite, in those cases, clinically, it's not the number that matters so much, but the direction. So if you somehow suspect a tumor, hepatoblastoma, and you follow it up with another AFP 3 weeks later, and it's gone down from 80,000 to 20,000, it's not a hepatoblastoma. Thrombocytosis can occur with these. We don't really understand why. and low serum AFP is actually a poor prognostic factor. The last couple are really shouldn't. This is just because this was my tumor, and you'll have to forgive me. So the correct answer is E. E is not true, and I know I went quickly, but that was probably one I didn't want to do. Oh, come on. Okay. 10-year-old girl, pain in her leg. She describes it as growing pains. She complains of recurrent leg pain that is unrelated to exercise and sometimes awakens her from sleep. Okay? I know I'm overdoing this diamond dung thing probably a little bit, but remember, pain that wakes you up is always a diamond. Okay? Physical exam reveals a slightly larger circumference of the left distal femur compared with the right. You obtain a leg radiograph. So, all right. Can you guys see that pretty well, especially the image on the left? Okay. If anybody marks osteomyelitis, it's game on. Okay. Okay. Do you see all those things that kind of look like, like starbursts, Codman's triangle? Okay. All right. So does this patient have patellar tendinitis? No. Do they have acute osteomyelitis? No. Do they have chronic osteomyelitis? Do they have a stress fracture? So all they have is osteosarcoma. I like this crowd. It's a tough crowd. I know the guys from Baylor keep entering the wrong answer. Okay. So, thank you for laughing with me. It makes it so much easier, but hopefully you're not laughing at me, but that's okay too. I'm not smart enough to know the difference. Being completely serious, there are not likely to be a lot of these questions on, but I want you to get every single one of them correct. I want these to be free. I want any oncology question you see to be a freebie. Okay? Got that. I remember what the goofy guy from Baylor said. And the way I think we're going to make them free to you is by remembering the story that goes with the tumor. You remember the story, you remember the tumor, and then you remember some facts about it. So neuroblastoma can be a variable presentation, but this is the sick kid with a mass. Okay? Wilms tumor is the well kid with hypertension and a mass. Also, it's the syndromic patient. Okay? All right? Hepatoblastoma. I love it. It's my tumor. In our big world, I'm the little guy who takes care of these tumors. But, it is important to know that this is a tumor that is very much linked to prematurity. We don't know why, perhaps TPN exposure. Osteosarcoma is a bone tumor that happens at periods of rapid growth. It does not typically have soft tissue involvement. Ewing sarcoma is the other bone tumor that you need to keep in your mind. It tends to have a little more soft tissue involvement and tends to more often be involved in the pelvis. You can't tell these apart on radiographs. We get them wrong all the time. You have to know that by biopsy. But there are a few things to kind of keep in mind. So those are the stories. Now let's just quickly look at a slide for each of them. And again, we'll go quick. I could go forever on these because this is my passion. Neuroblastoma is the most common abdominal malignancy. When you think childhood cancer, you're going to think it like this: leukemia, lymphoma, brain tumors, neuroblastoma. So we see a lot of these. Signs and symptoms, this is the crazy one. You can say neuroblastoma is the sick kid with the crazy symptoms. Proptosis, Horner syndrome, opsoclonus, myoclonus, periorbital ecchymosis, bluish sub-Q nodules. Treatment. Again, I just can't see you being asked anything about treatment. The only thing to know is that if you're young and you get this tumor, like you're a newborn, it's a very favorable prognosis and you can often just be observed. Those are the patients with the so-called 4S disease that you might remember from medical school. And other things that are favorable are if you don't have this oncogene MYC amplified and if you've got a lot of chromosomes in your tumor. But okay. I like the bluish sub-Q nodule picture. Maybe it'll help you keep the word neuroblastoma in mind. And this is actually one of my patients who gave me permission to use her picture. And what does she have? Can you see from there? She's got Horner's, yeah. And can you see why she has Horner's? It's got a big tumor in her chest that's going to, affect her sympathetic chain. Okay? All right. Why, I keep saying this neuroblastoma is the sick kid. In the older child who gets neuroblastoma, it's almost always going to be what we call high-risk disease. And so that's going to be tumor that shows up, everywhere. And there's this fancy test we do called MIBG. It's a chemical whose name I have trouble remembering, so we're not going to try. And it's taken up by neuroblastoma cells. And so on this kind of exam, the MIBG looks just like a bone scan. And these hot spots showing tumor show up dark. Okay. Now, there's going to be a little bit of stuff in the liver and the heart and the kidneys that are going to show up dark for MIBG. But all the stuff, and the salivary glands, but all the stuff that you see in the pelvis, that you see in the femurs, that's all tumor. And that's why these children are miserable at diagnosis. Wilms tumor, right below neuroblastoma. You will see these in your lifetime if you haven't already. You probably have seen a few. Second most common abdominal malignancy. Again, this is the association with the syndromic child. Aniridia, GU abnormalities, Hemi hypertrophy, Beckwith Wiedemann syndrome. Generally well-appearing, very, very treatable and curable with surgery, chemotherapy, and sometimes radiation. I put these in, not necessarily that you're going to have to recognize them, but helps you understand what a Wilms tumor is. On imaging, it has that claw sign, okay? And it's big. I ain't ever seen a small Wilms tumor. I think the smallest I ever saw was one that was picked up on screening with ultrasound in screening a child who had reflux. Okay. Hepatoblastoma, most common liver tumor in children, but still extremely rare. If you're going to remember one thing, it's prematurity. It can be associated with familial adenomatous polyposis, but again, if you're going to remember one thing, it's prematurity. Okay. Prognosis is good if it's not metastatic, treated with surgery and chemotherapy. And that's what a hepatoblastoma looks like. This is an MRI. The tumor is very heterogeneous, and it's just very typical. Okay. All right. The bone tumors. The thing to know about the bone tumors is they happen in the second decade of life. Why? When do you get a growth spurt? Second decade of life. Okay. You can't really tell them apart. Ewing's tends to happen in more different locations than osteo. What is the classic osteo location? If you're going to remember the story for osteosarcoma. The classic osteo location, distal femur, proximal tibia, areas of rapid growth. Okay. Surgery and chemotherapy are treatments, radiation for Ewing's. This is all, again, about finding this disease, or maybe not finding this disease, being lucky that your disease isn't biologically aggressive and metastatic at presentation. If it's non-metastatic, they're both very treatable and curable. Okay. We're going to talk some basic brain tumor facts. Okay. And, okay. 9-year-old girl complains of clumsiness for a week and headaches for a month. On physical exam, she has right dysmetria and right dysmetria and left upper and lower extremity weakness and numbness to pinprick. What's the most appropriate evaluation to establish the patient's diagnosis? Okay? Channel your inner Willie Sutton. Okay. Let's get some responses. Okay, I know somebody ordered the talk screen just to be a wise guy. How old was this child? No. Talk screen is really never a bad thing. I won't be a wise guy, because you always do have to worry about, you're going to get a lecture. I mean, really, to be a good pediatrician, you have to know toxicology, and you should always think it. But I do want to talk about, when you've got neurologic findings on an exam, in a question or in a patient, it's a diamond. You need to image, okay? It's kind of like saying, if the question says, worst headache of their life, right? Okay? So there are just certain, vocabulary words we want to look for. And just as a small teaching point, I chose, I probably should have thrown in CT as a choice. Where dysmetria, where do we think this child's tumor is? Cerebellum, right? Where do tumors occur in children? Above the tentorium or below the tentorium? Below, right? Adults, it's the opposite way, okay? What do you need to do to image below the tentorium? MRI. What happens when you get a CT? You can't see anything, right? All that scatter from the bones, okay? So that's just a couple things to keep in mind. Okay. I actually clipped this from a history and edited it a little bit. 6-year-old boy comes to the ER for ataxia, decreased activity, difficulty speaking, and facial droop. The patient also had crossed eyes. The mother first noticed that he was having difficulty keeping up with his karate class for the past month. She's noticed increased difficulty with walking, some slurring of speech, and facial droop over the past 1 to 2 days. The most likely diagnosis based on this history is... Okay. This is a basic science question in some way. It's a basic science or a clinical question wrapped in basic science. Where's this child's problem? So we've got facial droop, difficulty speaking, crossed eyes. Okay, those are all cranial nerves. Okay, so this is a question where the pathology is going to involve the cranial nerve nuclei. Okay, and so this is a brainstem glioma. This is the absolute worst thing that I take care of. It's the absolute worst thing to tell a family their child has. And so, what you're seeing on this MRI is kind of typical for what we call a brainstem glioma. Sometimes it's also called a diffuse infiltrating pontine glioma, because basically the tumor just infiltrates and takes over the pons. And this is kind of a classic picture of it. You think back to med school and your neuroanatomy, right? You had brain slices. Does this one look right to you? No. It's got a big, fat, pons. And this is just, again, a pons overwhelmed with tumor. So what we want to think about with brain tumors is that they can be a lot of different things. They can be benign, okay, a low-grade astrocytoma, or they can be malignant, like a medulloblastoma, or a high-grade glioma, an example of which is called the glioblastoma multiforme. Together, when you lump brain tumors together, they are the most common solid tumors, okay? How do they present? Headaches, vomiting. What's the sign of vomiting we don't like? Morning vomiting. I heard some mornings, right? Okay, why morning vomiting? Increased ICP? Is that what I'm hearing? That's what I'll go with too. Seizures, clumsiness, cranial nerve palsies. And again, that's what I wanted to see in that last question. I know a lot of you marked medulloblastoma, but think back and think about where the pathology is. Facial droop, slurring speech, eyes, those are all cranial nerve palsies. And if you're having multiple cranial nerves, you got to be getting the cranial nerve nuclei, you got to be getting the brainstem. These are tumors that are treated by surgery, radiation, and surgery always if possible, radiation sometimes depending on the patient age, and chemotherapy occasionally. So this is, when it comes to brain tumors, I want to just digress for 1 second. And we talked about Willie Sutton. Now we're going to talk about real estate. What are the 3 most important things in real estate? Right, and that's kind of how it is in brain tumors, right? Location, location, location. Well, it's really location and histology, but location is really important. And just as a clinician, I just want to share this with you. and I think it's something that could show up on a board exam, is craniopharyngioma. I mean, it's something we learn about from medical school, right? It's this cool example of, you know, how your visual fields can be affected, right? And at least that's how I was taught. And then you're told by those neuroscience guys that it's benign, right? Okay. It ain't benign. Okay. The pathology, you know, if you take it out, you know, may not have a whole lot of mitoses. It may not look anaplastic. But where is it? How valuable is the real estate? Okay. What do those patients get? They get diabetes insipidus. They get hypothalamic involvement. They get hypothalamic obesity. Okay. So in our world, who gets craniopharyngiomas? Well, when children get them, it seems to happen more often in the teenagers. Okay. Teenagers with diabetes insipidus. How compliant are teenagers in taking medications? Oh, so there is real morbidity and real mortality. So I just have a hard time calling that a benign lesion. And so again, you know, I think that's one that if I get invited back for next year, that I'll include as a separate slide, and we'll talk about craniopharyngiomas. But again, I want that to be a layup for you. Okay. You know, think about your visual fields, benign lesion, craniopharyngioma, but it ain't really all that benign. Okay. Survivorship. This will be on your exam. It's something that you need to know about because it's really truly no matter what you do, important. So you're evaluating a 17-year-old girl with a 2-week history of headache and morning vomiting. Oh my God. Okay. That's bad. Okay. At 3, she was treated for T-cell ALL and received cranial XRT. That's radiotherapy. On physical exam, she's afebrile. She has normal vital signs. She has a normal fundoscopic exam, normal neurologic exam. The reason she's got a normal fundoscopic exam is I probably did it, and I'm not sure I could find an abnormal fundi. Shh, don't tell anybody that. Okay. Bottom line. Okay. So what does Willie Sutton want to do? Okay. All right. Do we do a bone marrow aspirate? Do we do an EEG? Do we do an MRI of the brain, a lumbar puncture, or upper endoscopy because she's vomiting? Okay. I know some of you are probably thinking these are too easy, but again, I like them as teaching tools that you can go back to. So I want to get an MRI of the brain. And the reason being is, you know, we're going to go where the money is. And the money's there for 2 reasons. Number 1, she's got morning vomiting, right? And we said that's a sign of increased intracranial pressure. Number 2, she got treated with craniospinal radiation, right? Okay? So what can happen to survivors of leukemia who get craniospinal radiation? Brain tumors, okay? For the bonus round, can anybody want to shout out what the most common brain tumor they can get is? Meningioma is the most common. So though they can get really bad things like high-grade gliomas or GBM, you know, I've had the unfortunate business of taking care of an 19-year-old long-term survivor who was in his sophomore year of college, who was then diagnosed with a GBM and died. You know, T-cell ALL, just like this story. I mean, that's just not fair. Now, before anybody reads this question and says, you know, oh, this is just an oncology weenie asking me an oncology weenie question, this really isn't important, okay? This is based on the first question of my pediatric boards, okay? Obviously, I can't remember it, or I wouldn't be allowed to remember it, you know, verbatim, but it was, honest to goodness, a question about survivorship in a patient who was treated with anthracyclines, okay? So we have a 17-year-old boy who was treated for Ewing Sarcoma as an 11-year-old. His treatment included, that's a big number, I don't know if they gave me the number, but his treatment included anthracyclines, doxorubicin, okay? His annual echocardiogram shows a significant decrease in left ventricular shortening fraction. What is the most appropriate step in his management? Repeat the echocardiogram, obtain a MUGA to determine ejection fraction, biopsy the myocardium, initiate therapy with an angiotensin-converting enzyme inhibitor, or initiate therapy with a diuretic. Okay. Okay. All right. So the correct answer is D, and we're going to go through it, okay? You don't really need to repeat his echocardiogram. Hey, he's got changes, okay? Maybe it'll get better, but he's got changes. And what do anthracyclines do? They cause cardiomyopathy that can happen early, but more commonly late. We pick up this cardiomyopathy either by symptoms of congestive heart failure, or hopefully, because we know they're survivors and they're at increased risk, we pick this up by screening them annually with echocardiograms. So we got a bad screening test. It's probably not going to help us to sit around. We know the patient's at risk for this, and in his screening, he's gotten worse. So we ain't going to do it again. A MUGA. There's really no difference between measuring ejection fraction and shortening fraction. You know, maybe a MUGA is a little bit better, but an echo is pretty darn good. And if you know that you've got abnormal shortening fraction, you've got an abnormal ejection fraction. They can use, the cardiologists, you can do something clever and use what the Simpson's biplane method, and from an echo you can actually get ejection fraction. So that's an equivalent test. Don't want to do that. Myocardial biopsy, that would be interesting, and it's a lot safer than it sounds, or at least to me when the cardiologist talked about doing it, I thought, wow, I'm not signing up for that. But apparently it can be done really quite easily, and it would be very interesting, and you would likely see problems with the mitochondria in this patient. You'd see a mitochondriopathy. But the right answer is to put him on an ACE inhibitor. And just kind of for your general pharmacology, and I'm a real nerd. I have my boards in pharmacology, so I love drug questions. The ACE inhibitor is going to do two things, right? One, it's going to take care of afterload, and what's the second thing that we talk about ACE and heart failure? Remodeling. Exactly. It's going to prevent remodeling. Okay. 8-year-old boy, short stature, treated for ALL at age 3 and received cranial XRT. Are you getting the message that cranial XRT might be a bad thing? Okay. It is. It saved a lot of people's lives, but now in oncology therapy, we're trying to save people's lives without doing cranial XRT. On physical examination, his height is less than the 3rd percentile for age, and his Tanner stage is 1. I got this question from a colleague, and not being a particularly tall guy, I kind of find this question a little biased, but we'll go with it. The test result that is most likely to be abnormal for this little dude is testosterone, ionized calcium, gonadotropin-releasing hormone, growth hormone, or thyroid-stimulating hormone. All right. So the answer is, as most of you have got, is growth hormone. Testosterone, there are two messages to this question. And these are very important for you, again, for examination purposes and for being a clinician. Cranial XRT can do a lot of bad things. It can have effects on puberty. So his testosterone could be abnormal, but he's only 8, okay? So we don't really expect his testosterone to be elevated. Ionized calcium, yeah. Bone deposition, cranial XRT, not really an issue, but when we treat a lot of patients who've been treated with steroids in their leukemia or steroids for some other disease, are going to have problems with their bones. They're going to have osteopenia, and you're going to maybe want to get DEXA scans on them. They're at risk for avascular necrosis. I think that's something to store away, that survivors are also at risk for avascular necrosis. Gonadotropin-releasing hormone, yes, it's a possibility, but for him it really does look like isolated growth hormone deficiency. Radiation to the neck, what's it going to do to your thyroid? Bad things. Okay, so anybody who's had radiation to their neck is at risk for thyroid cancers or for hypothyroidism. Okay, so I really do think survivorship, it kind of fits with the philosophy of the board that, you know, look, 1 in 200 young adults is going to be a cancer survivor. Okay, and so we need to know these things. So radiation-late effects, they can include second cancers. They typically occur where the radiation was. So our little ALL boy who got craniospinal, or little girl, excuse me, the first question, and then had the morning vomiting, and we did our MRI, that's because she had radiation here, and she got her cancer here. Thyroid cancer in a Hodgkin's patient, because that field is going to include the thyroid. Hormonal effects, growth hormone deficiency after cranial irradiation, infertility if you radiate the testes or the ovaries. Okay. Chemotherapy has some late effects, not just something to be aware of and tuck way down on your knowledge list is that patients who've had chemotherapy can be at risk for a secondary cancer like an acute myeloid leukemia. Their kidneys can be in bad shape, as shown by they have a risk for hypertension, protein in their urine, and decreased glomerular filtration rate. High doses of some drugs like cyclophosphamide can increase your risk of infertility as well. Survivors, and we don't really understand it completely, you know, chemotherapy and treatment is really hard on the body. They're more likely to have metabolic syndromes and are at increased risk for obesity, heart disease, liver dysfunction, second cancers, and so long-term follow-up is very, very important. Okay, not cancer. I think this is important too because I'm guaranteeing you you'll see some questions that you're going to wonder if the patient has cancer and they don't. So let's make sure you can get those correct. You will see some variation, I'm pretty certain, of this question, okay? An obese 16-year-old girl on Accutane with severe acne presents to your office complaining of nonspecific headache and pain and pulsating sounds in both ears. On fundoscopic examination, you, not me, note papilledema. But the remainder of the exam, including your thorough neurologic evaluation, is normal. So what's your most likely diagnosis? Okay. Does this patient have cranial nerve findings? No. Do not check brainstem glioma. Okay? All right. They're kind of old to have a medulloblastoma. Don't check that. Okay? So pseudotumor cerebri is, you know, I can't say that I've really seen it very much. Maybe once or twice, you know, in the time I've been doing this, and my number of years is starting to add up. But it seems to be a favorite board question. And we're going to go back, and there are, you know, I hope I haven't insulted you with this question, but, you know, we did pack a lot of pseudotumor cerebri risk factors into this question. So let's go through and check them off. Obese, risk factor? Accutane. Okay. Okay, symptoms, nonspecific headache and pulsating sounds in the ears. Are you going to see papilledema? Yeah. Okay. So what would make this child feel better? Yep. Okay. So you'd have elevated opening pressures. What else can cause pseudotumor cerebri? Eating polar bear liver. Okay. So don't do it. Okay. Ralph Feigen taught me that, so I know it's true. And what it is loaded with vitamin A, and it's the vitamin. Yeah, that's the word I was looking for. Having a lot of vitamin A that does that to you. Okay. 11-year-old boy with a seizure disorder on valproic acid presents with fever to 102. He appears mildly ill. His physical exam demonstrates no lymphadenopathy, organomegaly, skin lesions. His labs show a normal hemoglobin, a normal white count, a platelet count of 98,000, and a creatinine of 0.5 milligrams per deciliter. Why does he have thrombocytopenia? Okay. Have I seen patients with acute lymphoid leukemia present with only one cell line down? Yeah. Not always. Very rarely. I remember a Downs patient with really bad bone pain and only had thrombocytopenia, had normal white count, had normal hemoglobin. But generally, and especially for test-taking purposes, leukemia is not going to be in your differential with just one cell line down. Okay? Hemolytic uremic syndrome. Where was the uremia? I didn't give you a BUN and the creatinine was okay, so I should have given you a BUN. Drug-induced thrombocytopenia. Yep. There's a reason the drug is mentioned, and there are drugs, and the antiepileptics are ones that can induce thrombocytopenia. They can induce leukopenia, and those are all kind of very important things to keep in the back of your mind. Why is this not ITP? Okay. We're going to talk about ITP in the heme section. But again, what I want you to do is make a mental image, a story for the patients in the disease, and then hang the effect, and then hang knowledge about that disease, on that picture. Hang it, attach it to that picture. So ITP is going to be your patient who has a platelet count of 2, of 5, or of 10. It's always going to be very, very low in children. It's going to be something that's very sudden onset, and it's usually going to be someone that's well appearing. HSP? No. Okay. So the things that you want to think about in your not cancer kind of list are pseudotumor cerebri, some bone lesions. There's the famous osteoid osteoma with pain worse at night that responds to NSAIDs. It will look different, and I should have brought my picture of it. I don't think I have it here. Is that it's going to be a very simple radiolucent image on the bone with some sclerosis surrounding it. These are kind of hard calls. I don't expect these to be necessarily things that you'll have to differentiate, but if you see a normal, if you don't see a bad looking, I think your osteosarcoma X-ray is going to be really nasty looking with all those findings that we talked about, the starburst appearance, the Codman's triangle, all those things that are kind of classic that you need to remember, and that your benign lesions are going to look benign. I know that's kind of profound. Myelosuppressive drugs, the antiepileptics, antibiotics. Just about any antibiotic given chronically can have some effect on the marrow, but there are ones that are classics. What does Bactrim do? Drops your counts, right? You treat somebody for PCP, that was one of your potpourri questions at the end. Treating patients for PCP, you're going to drop their counts with Bactrim. I think it's possible that you may need to recognize something like a bone marrow failure syndrome, but we'll talk a little bit about that kind of stuff in the heme part. So this is kind of based on something the American Cancer Society sends out, and you can store this away as clinicians, but I think it's also something to kind of put in your back pocket for your test taking. So the American Cancer Society has this crazy mnemonic. Is that no? Yeah. And I mean, and I really don't like it because I don't know about you guys, but whenever I was in medical school, all our mnemonics had to do with, I guess I hope this doesn't come across bad. They all had to do with sex, right? This is pretty boring. So this is children, okay? And I couldn't get it all on one slide. So C, continued or unexpected weight loss. So again, that'd be a diamond in a question for that you need to do something to, consider something about cancer. Headaches with morning vomiting. I think we've beaten that into you guys. Increased swelling or persistent pain in bones and joints, possibly with limping. Refusal to bear weight, okay, has to have leukemia on your differential diagnosis. You're just going to see it over and over in your careers, and you're going to see it over and over in examinations. One thing to remember when you talk about osteomyelitis that I still remember from one of my in-service exams was point tenderness. That's considered, both on your physical exam and on your test-taking skills to be something that's closely linked with osteomyelitis rather than leukemia, because you're going to hurt all over with leukemia. Imagine a few of you guys have children in here, and I think one of the challenges that we face as pediatricians in working up someone who refuses to bear weight is how many toddlers are really good at localizing pain? Yeah, that's ridiculous, I just think of my own kids whenever I do this. It's just like I couldn't get anything out of them. So, we can't get it out of our own patients. Obviously, lumps or masses should make you think cancer. When you talk about nodes, they need to be big. Now, this is from the American Cancer Society, and boy, I hate this one. D, development of a whitish appearance in the pupil or sudden change in vision. I mean, now that's a lame part of a mnemonic, okay? What's that for? Blastoma, right? Exceedingly rare, but a potentially interesting question. Bilateral retinoblastoma makes you think familial mutation in the RB gene. Okay. Recurrent fevers not due to infection. Again, fever, FUO, fever of unknown origin. Oncology needs to be kind of part of that workup. Particularly can lead us to the path of leukemia or lymphoma. Excessive bruising or bleeding. Petechiae. You guys know what a petechiae looks like. You'll see them on the picture part of your board exam. Noticeable paleness or prolonged fatigue, and that's their children. Okay? All right. So they're different than adult cancer. I just say that for my own plug. We do well in treating and curing people. They're characterized by these vague common symptoms. They're treated with multimodal therapy. And just to let me make a plug as an oncologist, they are curable, and it's a very rewarding field. So please keep a keen eye out for the diamonds. When you're studying, this is especially important in oncology because you're going to have a lot of material. I mean, a lot of other stuff. There's going to be a lot of infectious disease to learn. But I really don't want, I want you to have gotten a few diamonds from this lecture so that there isn't a single oncology question that you miss on the boards. All right, so this is, we're going to talk about the hematology portion. I called it red, white, and jaundice. But it's got the same theme again, and we're going to talk about diamonds and dung. Okay? So again, look for the diamonds. Look for the diamonds when you're studying, and look for the diamonds when you're taking the test. Okay? We're going to try to cover the content areas, and we're going to try to identify those diamonds in each of those content areas. We're going to talk about red cell disorders, white cell disorders, bleeding and clotting disorders, and a little bit about newborn hematology. Okay. Red cell disorders. We're going to talk about anemia and iron metabolism. So on a routine screening complete blood count, a 1-year-old is noted to have a microcytic anemia. A follow-up hemoglobin electrophoresis demonstrates an increased concentration of hemoglobin A2. What is the most likely diagnosis? Iron deficiency, beta thalassemia trait, sickle cell anemia, chronic systemic illness, or lead poisoning? So go ahead and cast your votes. So we got some hematologists in the group, okay? So when we have an increase in hemoglobin A2, we have beta thalassemia trait. We'll go through microcytic anemia now. So what causes microcytic anemia? Microcytic anemia, the classic, the one we got to know as pediatricians, is iron deficiency. But what you got to know as a pediatrician, and you got to know for the board exam, are some other causes. Lead poisoning, guaranteed to be a question. What lead poisoning is a couple, you see some basophilic stippling of your red blood cells, and you also see an elevated blood lead level. Now, those of us from Texas don't see much lead poisoning. Those of you guys from the East and the Midwest probably know as much or more about lead poisoning than I do. You've certainly treated more patients with lead poisoning than I have. Thalassemia trait, and thalassemia trait is one that you really need to be aware of because it ain't iron deficiency. All microcytic anemia is not iron deficiency. And so in thalassemia trait, you can often recognize this because the MCV, the size of the red blood cells, the mean corpuscular volume, is often out of whack in its smallness. You got a good microcytosis going on, but not a whole lot of anemia. It's also characterized by elevations of hemoglobin hemoglobin A2, and often on the neonatal newborn screen by the presence of Bart's hemoglobin. In the sick child, and we see this a lot in oncology clinic, you'll see this with infections, you'll see this with rheumatologic diseases, you can have anemia of chronic disease. What's going to characterize your anemia of chronic disease is the fact that your iron is low, that your total iron binding capacity may be normal, but your ferritin is going to be normal or elevated, okay? Really what anemia of chronic disease is, you got enough iron. It's just the chronic disease, the inflammation, is interfering with the body's ability to do what it needs to do with that high ferritin. You can also get microcytic anemia if you have some of the other odd hemoglobinopathies, like hemoglobin C or hemoglobin E, and it can even come up with copper deficiency or zinc poisoning. Okay. Our second question. Okay. Now this is one loaded with a lot of diamonds. So a 4-year-old, previously well boy of Middle Eastern descent develops pallor, dark urine, and jaundice. He is taking Bactrim for otitis media. So now this question I made too easy. All right. So we already told you he's got an acute hemolytic crisis. But why do you know he has an acute hemolytic crisis? Well, he's pale, okay? So he's probably anemic. Pale equals anemic. Dark urine, okay? That's a bad thing. That's jaundice. So he's hemolyzing, okay? So what's causing his acute hemolytic crisis? Does he have G6PD deficiency? Does he have autoimmune hemolytic anemia? Does he have sickle cell disease? Does he have drug-induced hemolytic anemia? Does he have hereditary spherocytosis? Okay. So go ahead and give me your responses. The 7% of you that said drug-induced hemolytic anemia, you probably have the right to complain a little bit because I'm going to mark that wrong, and we're going to call it G6PD deficiency. But what triggers a hemolytic crisis in G6PD? We'll talk about more of this on the next slide, but it's things like drugs, right? And Bactrim's one of them. There's a whole long list. I wouldn't bother remembering the list. I look it up when I'm worried about it with G6PD. Just know that if somebody gets a new drug and they develop a hemolytic crisis, like the patient described in this question, it's really a clue that they have G6PD deficiency. We'll talk more about autoimmune hemolytic anemia, but usually there's a triggering factor for that, and like an illness, sickle cell disease, certainly can have hemolytic crises, though it's usually there's a history. I mean, there's always a history, and the presentation isn't going to be sudden in onset like this. Hereditary spherocytosis, those patients can have crises as well, but again, typically something about the history. So what is it in this question that made us think G6PD deficiency? Well, we said our patient was from the Mediterranean, right, or Asian, or Middle Eastern, Arabic. So it's often seen in African Americans, Asians, people of Arabic descent, or basically people kind of from that Mediterranean part of the world. It can be very mild, or it can be severe, and the hemolysis classically can be triggered by food or drugs. Everybody's got to know fava beans, right? Even if you don't even know what a fava bean is, even if you've never eaten a fava bean, and I probably fall into that category, you need to know that, with respect to G6PD. Bactrim's a real common one. The anti-malarial drugs that I can't remember, but Tommy can, are all ones that can trigger hemolysis as well as infections. Could we test this child in his acute phase to determine if he has G6PD? Right. Because all the cells that were G6PD deficient are gone. Okay. All right. So how do you manage this? You don't really have to do very much. Avoid fava beans. Is that what you said? Yeah. Avoid fava beans. You really have to prevent exposures. And if this happens, you address the symptoms, based on their severity. And in some cases, patients like this will require transfusion. I did have a fava bean induced. I did have a patient with a fava bean induced ICU admission for severe anemia, severe symptomatic anemia. Okay. All right. Question number 3. All right. On routine examination, a 1-year-old boy is noted to be pale. He is in the 75th percentile for weight and the 25th percentile for length. His physical exam is otherwise normal. His CBC shows a hemoglobin of 7.4, a white count of 7, a platelet count of 750,000, a reticulocyte count of 0.5%. Sickle cell testing is negative. Stool guaiac is negative, and his MCV is 65. So taking our diamonds and dung approach, okay, weight and height, what do you think? That's dung, kind of, on this one. He's kind of normal shaped, right? I mean, there's 75 and 25 are all right. I mean, kind of like me, 75 weight, 25 height. I'd like to change that, but there's nothing wrong with it, right? It's not pathologic, okay? So normal physical exam. His hemoglobin. He's anemic, right? White count. Normal. Platelet count. High, elevated, okay? Does he have leukemia? No, okay. Reticulocyte count. Yeah, low for his anemia. Sickle cell testing, negative. Does he have sickle cell disease? No. I mean, don't doubt, in questions on tests, if they tell you something, don't assume it's a false negative or a false positive. Go with what got you there. Guaiac negative, okay? What is that piece of information telling you? He's not bleeding, right? MCV is 65. What should his MCV be? 70-something, higher, something like that. It shouldn't be 100, right? Okay. So, what are you going to do for this guy? Are you going to transfuse him? You're going to give him oral iron sulfate? Are you going to give him intramuscular iron dextran? Are you going to put him on iron fortified cereal? Or are you going to give him calcium? Okay. Okay, somebody's being a wise guy. I know it. I know it's you, Isa. So, all right. So you're not going to transfuse him. Is this patient symptomatic? No. And it's one thing that on board exams is going to be emphasized to you over and over from the hematology folks who write them, are that you don't transfuse for numbers. You always transfuse for symptoms. And so we described a child with a normal physical exam. So there's no way this child gets a transfusion. There are colleagues of mine who will go down to the ER and see the child who's been drinking milk, drinking 40 ounces of milk a day and is 2 years old, and see them with a hemoglobin of 4.5 and send them home on iron. I can't do that, but again, there are people who really can live by that guideline of I'm not going to transfuse unless you're symptomatic. And that's a good guideline to take into examinations. It's a harder guideline to sometimes follow in practice. The things that would tip you both on an exam and in clinic to transfusing a child with iron deficiency anemia are things like a gallop, really bad tachycardia, perhaps poor feeding. Those would all be things that would kind of tip you to transfusion. If we had taken this child's hemoglobin of 7.4 and instead made it 4.7, how would we have transfused that patient? Slowly, right? How did this patient get anemic? Slowly. How do you transfuse them? Slowly, right? So, one rule of thumb is you can use a number that's about equal to their hemoglobin. So if you got a hemoglobin of 4 or 5, you might give them 5 cc's per kilo of packed red cells. And you do it slowly. You might do it over 3 or 4 hours. Okay. There are more iron formulations than I can keep track of. And I don't think any of them have made it to the test, to the board exam phase yet. So for now, we're going to go with ferrous sulfate as our answer to all iron supplementation questions. So what dose of iron would you like to give this child? About 3 to 6, 4 to 6. You're not going to be on the 2 to 3 range, okay? You want to, because this child you're not just maintaining iron stores, you're trying to replenish iron stores. This child's ferritin could be 2, right? Okay. Intramuscular iron dextran. I don't think I've ever given, I've done this, 6, 7 years now, 6, then 3 plus fellowship 9. I don't remember giving, parenteral iron maybe once or twice. There really aren't a whole lot of indications for it. Often when you transfuse, you're getting just enough of an iron load as it is. Okay. So iron deficiency anemia. You got to know this. You're guaranteed to get questions on it, and you're guaranteed to see it. You need to know it to be a good clinician. Okay. It's like the number 1, 2, and 3 reasons that we all see children who become iron deficient is diet, right? And you will get questions, whether it's a heme question or a general peds question about this. How much milk does that toddler, need to drink? What's too much when you're 2 years old? What, 16 ounces now? 16 to 20 ounces? Yeah. Pardon? Yeah, more than 24, big flag. So when you see somebody who's getting 32 or 36, and you will see this both on exams and in practice, they have a problem with their diet. But diet isn't the only cause. Sometimes you can look at, you can have something like a Meckel's diverticulum, ulcers, polyps. One that's often seen is irritation by cow's milk with allergies. And I can't say that I've ever seen it, but worm infestations are also on the differential diagnosis. You can have decreased iron is absorbed in the duodenum, and you can have inhibition or decreased absorption, and that's classically associated with lead poisoning, but it also can be associated with celiac disease or tropical sprue. The things you want to tuck away for your iron deficiency question, the diamonds that you want to think of that you're going to have to know for iron deficiency, are the child who eats dirt, right? Okay, and pica, and pica is really eating any non-nutritious, non-food type substance, whether it's dirt or whatever. But this will be something you see in practice, and it will be something you see on the board. Tachycardia, heart murmurs, gallop to me is really a sign of enough impairment that we would consider that something to be transfusion worthy. In the cases of chronic iron deficiency, you can see impaired growth. There's a lot of evidence now that iron deficiency is linked with cognitive dysfunction, altered attention span, behavioral issues, and what's really most important for kids, school performance. Okay. If you're going to see any pictures, and I love pictures, as you can tell, you're quite likely to see a picture of iron deficiency anemia in your picture book. How much central pallor should a red cell have in terms of the radius? 1/3, maybe a half at most, somewhere between 1/3 and a half. Now this is a little washed out, but how much central pallor do these guys have? A whole heck of a lot more than that. So what are we going to look for in a smear that's going to tell us iron deficiency? Pallor, sizes, and shapes, okay? So what are you going to see? Lots of pallor, lots of different sizes, lots of different shapes, okay? And those have a lot of fancy words. So microcytosis, you're going to see small red blood cells. So they're going to be, if you were comparing them to a lymphocyte, what would they look like? Smaller? Yeah. Increased RDW. RDW is a fancy word that talks about the distribution in sizes of a red cell. So when you look at a lab report and you see the RDW is higher than normal, that means you got a lot of cells of a lot of different sizes. That distribution, instead of being narrow, has become much wider. And again, that's kind of going to be classic for iron deficiency anemia. Anisocytosis, poikilocytosis, again, variation in size and shape. Those are our fancy words. You can sometimes see a normal reticulocyte count, but often you're going to see a low reticulocyte count. And if we think back to the iron deficiency question we just did, what was that patient's platelet count? Often going to see that kind of thrombocytosis. Iron deficiency is, definitely on the differential of thrombocytosis. Okay. Going back to cancer for a second. Is thrombocytosis, do kids have myeloproliferative disorders that give them thrombocytosis? No. Okay. Is thrombocytosis in a child something that's usually dangerous? No. Is thrombocytosis in a child something that's reactive? Yes. It's going to be reactive to illness, it's going to be reactive to a stress like iron deficiency anemia. And what do you do about it? Nothing. You treat whatever is going on, or let time take care of whatever's going on, and the thrombocytosis is going to go away. So the management for iron deficiency anemia, for now, is oral ferrous sulfate. I think that is the correct answer going forward. There may be other iron formulations that sneak their way onto the board exams in the future, but not right now. You need to identify and correct the cause. If it's diet, you need to get that child to stop drinking 40 ounces of milk. If it's bleeding, we need to do something about the bleeding. Again, as I mentioned, red cell transfusion is really only for severe anemia, for this concern about cardiac failure. The word, again, that I'd look for the diamond that I'd look for both on my exam and in reading my board question would be a Gallup. Parenteral iron, really only in special cases. Again, maybe someone who has a problem with some type of celiac disease. And usually it's only done after we've done some kind of oral iron challenge. What is the most common reason that a child does not respond to, a child with iron deficiency anemia does not respond to oral iron therapy? Non-compliance, right? Okay. So how do you guys teach them, right? You take it with milk, right? Okay, no. All right, good. Somebody's still awake. So, you're going to take it on an empty stomach, or you might take it with something acidic like orange juice to help with your absorption. Okay. Okay. Question number 4. A 6-month-old girl who was born in Nigeria presents to the office with fever and irritability. Physical examination reveals a fussy infant who has anorexia, a low-grade temperature, and swelling of all the fingers of the right hand. What is the most likely cause of this symptoms? Cellulitis, allergic reaction, malaria, sickle cell disease, or trauma? Okay. This is to me like I think this is a pretty good question. I like this question. I'm sorry to kind of toot my own horn, but I like it because it's lousy in one way, because you don't really know. I mean, could this child have cellulitis? Yeah, why not? But is it the most likely? No. I mean, you'd want to look at it. Could it be an allergic reaction? Maybe if they got stung by a bee or something, but that's not in the history. Could they have malaria? Yeah, but why hand swelling? But it's a vague question without a whole lot of information, so I think it's a good board question. and it wants you to recognize the clinical entity of dactylitis. Okay, so dactylitis is how children with sickle cell disease present when they're young. And what is dactylitis? Painful swelling of the hands and fingers, or the toes, but most likely hands and fingers. Could it have been trauma? Yeah, but there's no history for it. Okay. So sickle cell anemia. Sickle cell anemia is caused by a gene mutation in the beta globulin. The sickled red blood cells have shortened survival. You can also see, depending on the type of sickle cell disease that you have, in addition to sickling, you can also see some target cells. Laboratory feature-wise, it's usually a normocytic anemia, though patients with hemoglobin SC can have a microcytic anemia. You might want to make a note of that. We see an increased reticulocyte count. We often see thrombocytosis, and we often see leukocytosis. Why do you see thrombocytosis, and why do you see leukocytosis? I don't really know. The best answer that I've always gotten is that the bone marrow is working really hard, because a normal red blood cell has a lifespan of about 120 days. In a sickle patient, they think the lifespan of a red cell is about 45 days. So, to make up for that and maintain some kind of steady state hemoglobin level, the bone marrow has to work very hard. And many of those growth factors just have some kind of cross reactivity such that you're going to increase the platelet production as well as the white cell production. Again, on a sickle cell smear, we can see sickle cells, polychromasia, as well as some Howell-Jowl bodies, and occasionally target cells as well, especially with hemoglobin SC. Newborn profiles, okay? If all you see is fetal hemoglobin and S, what do you have? Sickle cell. You got to see some A. If you see A, S, and F, what do you have? Sickle trait. Okay? So that's very important. Okay? We talk about hemoglobin F. What is the drug? And we're using it like crazy now at Baylor. What is the drug that we often treat patients who have sickle cell disease with? How does it work? That's right, and that's the standard answer. But one other answer that you need to be aware of is that it actually does, it's a chemotherapy agent, right? So it suppresses the bone marrow a little bit and actually will decrease the white count as well. And that high white count is thought to play a role in kind of the inflammatory response that makes sickle pain and sickle crises worse. So, you guys have trained, so and you've probably seen every one of these, but let's just go through them again. Hand-foot syndrome, dactylitis, how do you treat it? Hydration and analgesics. Vaso-occlusive crisis, hydration and analgesics. Acute chest syndrome, okay? What is the difference between pneumonia in a patient with sickle cell disease and acute chest syndrome? Nothing, okay? I'm sorry to be a wise guy, but I just, an infiltrate, pneumonia and sickle cell and acute chest are the same thing in a patient with sickle cell disease. We're going to treat it with hydration, pain medication, oxygen, simple transfusion if there's room, and antibiotics. Our antibiotics are going to include a cephalosporin as well as a macrolide. And why is that? If you look back at the New England Journal papers on acute chest syndrome, when they identify a pathogen, the most common pathogens are chlamydia pneumonia and mycoplasma. What is much more commonly identified as a cause than those? Nothing. Usually it's idiopathic. We think acute chest can be associated with these infections. We also think it can be associated with fat embolism. But most of the time, we don't know what causes it. Is it infarcts? Is it? We don't know. But you got to treat it like it's an infection, and you have to use a cephalosporin, and you have to use a macrolide. Splenic sequestration. How do you treat real splenic sequestration? Transfusion. And you transfuse just, you can transfuse quickly. We debate over the amount that we transfuse. Often we will transfuse a little bit less volume. We can do it quickly, but we'll do less volume because we're worried about the phenomena of autotransfusion, right? You transfuse, you got this big spleen, and then all of a sudden, whoop, the hemoglobin goes way up as the spleen goes way down. So typically we may transfuse a slightly smaller amount, not your classic 10 cc's per kilo, but something on the order of 5 to 7. This will all depend on what the hemoglobin is. This does not have to be given slowly, though, like in iron deficiency anemia. Why? How did the patient with splenic sequestration become anemic? Fast or slow? Fast. So how can you give the blood? Fast. Okay. Aplastic crisis. Well, you got to treat it only one way, and that's with PRBC transfusions. If you're going to think of one infectious cause for aplastic crisis, parvovirus B19, slap cheek, all that kind of stuff. Okay. Stroke. Probably the most important thing we've learned to do in treating young folks with sickle cell disease is to try to prevent strokes. And so I think it's very important that as a pediatrician, taking tests and preparing to take care of patients, that you know about prevention. And the way we do it is transcranial Dopplers. Okay? We send them for Doppler screening, and if their transcranial Dopplers are abnormal, they get put on either chronic transfusions or get set up to do, they get on chronic transfusion therapy. What made me stumble on my words here, I apologize, is what is the management? What is the management, the acute management of a patient with sickle cell disease and stroke? Exchange transfusion. Okay, you don't have to worry about it's not this drug or that drug, and you're not it's not about that. It's about getting their S fraction less than 30%. So we do that with exchange transfusion. Priapism. So priapism, we all know, painful prolonged erection, and that's treated with hydration, red cell transfusion, irrigation. There are some drugs, and I'm blanking on it, that can be used to help with priapism, but primarily with hydration, analgesics, red cell transfusion, and if necessary, you call the urologists and ask them to do irrigation, which is not something that I've seen, and as a guy, I don't really want to see again. So, other hemoglobinopathies. Not all sickle cell disease is hemoglobin SS, right? You can have symptomatic patients who have hemoglobin SC disease. Usually their phenotype is milder, right? They tend to keep their spleens to an older age, whereas a patient with hemoglobin SS usually auto-infarct their spleen in the first couple of years of life. A patient with hemoglobin SC will keep their spleen into their teens, often, maybe even into their 20s. The smear on a patient with hemoglobin SC can show more target cells. Again, generally, a more milder phenotype characterized by a higher hemoglobin, can be as high as 10 or 11 in some cases, and usually characterized by microcytosis. Thalassemias, the sickle thals. Well, no, excuse me, the other hemoglobinopathies, the thalassemias. We can see alpha thal and beta thal. Okay, the thalassemia genes are inherited in groups of 4, and when you inherit a thal trait, really you just have small cells and you go on with the rest of your life. When you have only 2 of the 4, you can have some symptomatic anemia, and when you have 3 out of 4, that's when you get into what is called thal major. Beta thalassemia we talked about as inherited by itself. It's just thal trait, and again characterized by a microcytosis and perhaps a mild anemia. In terms of the sickle cell disease, we can see what we call S beta plus, where you have some production of A2, and those patients are more like hemoglobin SC patients and tend to have a milder phenotype. And then you have patients where you have no production of the A2, and you have S beta 0, and those patients' phenotype is very much like a patient with SS disease. Okay. All right. Still on red cells. We have a 13-year-old boy who complains of increasing fatigue several days after a URI. Findings include pallor, scleral icterus, and a palpable spleen. Laboratory studies reveal a low hemoglobin, a reticulocyte count of 10%, unconjugated bili of 2.8, and an elevated LDH of 4,782. He had a normal CBC at a sports physical 1 year ago. What lab test will be most beneficial? G6PD, direct Coombs, osmotic fragility, his EPO level, or hemoglobin electrophoresis? This is a tough one, but this is kind of a classic description of a kid who has an autoimmune hemolytic anemia. He doesn't have G6PD, or at least we can suspect that he doesn't have G6PD, because there hasn't been, in our test-taking skills, there isn't a trigger for his disease that's been identified. Look, he was completely healthy a year ago. Is there any trigger? Where are the fava beans? Does anybody see the fava beans? Okay, so he doesn't have G6PD. He's not on a new drug. He's not from the Mediterranean. He didn't eat fava beans. So we're not going to worry about G6PD. All right, so now what we got to sort out is some of the other things. Well, hemoglobin electrophoresis. Okay. Does he have sickle cell? No, because you don't usually present with your sickle cell disease at 13 years of age. You've had some problem along the way. You need to look at his EPO level. I'm not sure I've ever ordered an EPO level. Has anybody here ordered an EPO level? I mean, there are not too many times that we've ordered them, right? And your EPO levels are going to be affected when you have kidney disease, so we can scratch that off. What it comes down to are, do we think that he has some kind of immune hemolytic anemia, or do we think that he might have some kind of other hemolytic anemia, perhaps from like a red cell membrane defect like hereditary spherocytosis? What gives us a clue on this is that his age. Hereditary spherocytosis is not something that's typically going to wait to show up until you're 13 years of age. Hereditary spherocytosis is something that is going to be linked with a family history. And the triggering insult here, this URI, it could go either way, but the profound hemolysis that he's got going on and his age really tend to favor an autoimmune hemolytic process. So autoimmune hemolytic anemia, it can just happen. We can all be too idiotic and too pathetic to figure out what caused it, or it can be secondary, associated with some type of infection. Often by a viral infection. There's some link between autoimmune hemolytic anemias and mycoplasma infections. It's characterized by very acute hemolysis, usually a severe anemia, a profound reticulocytosis, though I want to caution you, probably more as clinicians than as test takers, that just because the reticulocyte count isn't really high right when you diagnose someone with a bad anemia, don't rule out hemolysis. The bone marrow just may need a little bit of time to catch up. Hyperbilirubinemia and hemoglobinuria. Sometimes mild splenomegaly or large splenomegaly, a positive Coombs test. Treated with steroids and, sick enough, even though you got hemolysis going on, you have to transfuse these patients. And this is the case where, as a hematologist, we ask for least incompatible blood. Okay. All right, white cell disorders. Okay, routine screening CBC, you got a 1-year-old, has eosinophils. What's causing this? A bacterial infection, a URI, a fungal infection, invasive parasitic infection, or tuberculosis? Okay? Get this wrong and I don't know. Okay. This is a place, and I apologize. Next year, if I'm invited back, I'm going to put a slide in. I need to put a slide in with a sickle smear, and I need to put a slide in where I'm going to make you identify eosinophils, because this is the kind of place where you could have a smear that shows you a bunch of eosinophils, and they don't tell you the patient has eosinophilia. And as most of you have correctly pointed out, what causes eosinophilia is most likely, in this case, going to be a parasitic infection. Eosinophilia can happen to a minor degree in patients with asthma, hay fever, or other allergic reactions. It can happen in those patients, those kids who have atopic dermatitis, who have pemphigus and pemphigoid, and those things I barely remember. But they will typically have mild eosinophilia. If you ever see a profound eosinophilia, it's going to be invasive parasites until you sort out otherwise. It can be something that is associated with malignancy. You can see it with Hodgkin's and some non-Hodgkin's lymphomas. You can see it in myeloproliferative disorders, but again, that's mostly in adults. And there is, in the myeloid leukemias, eosinophilic variants. of which I have never seen. It can be associated with some gastrointestinal disorders. Again, that falls into the category of something that's driven by allergy. Some immunodeficiency disorders that I'm not smart enough to talk about. Okay, question number 7. An otherwise healthy child who drinks goat's milk regularly has a CBC checked at his 1-year checkup. The peripheral smear shows many multi-lobulated neutrophils. My problem was I couldn't find a picture of this that I owned. So I want anybody who has a computer in front of them to Google multi-lobulated neutrophils and show your neighbor a picture or look it up tonight. Because this is something you are quite likely to see on the board exam, okay? And it will not be subtle, okay? It's going to be a lot of lobes, and it ain't going to look normal. So if you see that and you have this multi-lobulated neutrophil, what is it associated with? Sickle cell disease, iron deficiency, lead poisoning, Pelger-Hewitt nuclear anomaly, or folic acid deficiency. So, you guys are on top of it. It's associated with folic acid deficiency. It also can be associated with B12 deficiency. And you do need to sort out the cause, because if you treat everybody with folate, you can hide a B12 deficiency. But again, I would anticipate seeing this on your examination. So folic acid deficiency can occur from dietary deficiency. If you're drinking goat's milk. It can occur from defects in absorption. There are some errors of absorption and metabolism. There's some drugs, some of the anticonvulsants, and the drugs that we use to treat leukemia, like methotrexate, cause folate deficiency. They try to interfere with the folate pathway. So that's why we're trying to make people folate in some way folate deficient, so we're trying to make their leukemia cells folate deficient. Usually there aren't, unlike a B12 patient, there won't be any neurologic symptoms. It'll be a macrocytic anemia. The hypersegmented polys is the classic. You will see it on a board exam. You can see this with neutropenia, and you can also see it with thrombocytopenia. You need folate supplementation, and you need to try to identify and treat the cause. Okay. B12 deficiency has similar effects to folate deficiency, although it can be associated with neurologic symptoms. It also causes a macrocytic anemia. It does have neutrophil abnormalities, and as you probably remember learning from medical school, it can be associated with pernicious anemia. Okay. So you've been following this patient in your clinic. Since he's been about 8 months of age. He's now 13 months. And you've gotten several repeat CBCs, which have shown a white count that's below normal, somewhere between 2,000 and 3,000. And you've seen that his absolute neutrophil count is less than 400. You send him off to the knuckle-headed hematologist, and he does a bone marrow aspirin on him, and he sends you back a report that says there's normal granulocytes with normal trilineage precursors. Okay, so what is the pathophysiology behind this condition? Okay, infiltration of the bone marrow by leukemic blasts, bone marrow failure with inadequate production of myeloid precursor cells, autoantibodies to granulocytes, defects in granulocyte adhesion, vitamin B12 deficiency. So if you're going to talk about, and these are kind of classic questions that you're going to get on exams, right? They don't just ask you what the name of the disease is. They're going to ask you, what's causing the disease, what's the pathophysiology, or how do you treat it? So when we answer these questions, let's first of all talk about what this disease is, what its pathophysiology is, and how do we treat it, okay? So what is this disease? Probably chronic benign neutropenia. Exactly. And what is the pathophysiology of chronic benign neutropenia? It's actually an autoimmune disease. So it's autoantibodies to granulocytes. We don't have infiltration of the bone marrow by leukemic blasts, right? The report even told us that. We don't have bone marrow failure because remember we had normal granulocytes, normal maturing trilineage precursors. So, the bone marrow is working just fine. In bone marrow failure, you're going to see hypocellularity and you're going to see things that aren't progressing, okay? You might even see, extra neutrophil precursors because, like I said, the pathophysiology is autoantibodies. This has nothing to do with adhesion and nothing to do with vitamin B12 deficiency. So we talked about you've been able to recognize what the disease is. You know its pathophysiology. So how do you treat it? Really, for the most part, reassurance. Chronic benign neutropenia is a disease that really occurs in healthy kids. It's the most common cause of neutropenia in these healthy children. Its median age of detection is about 8 to 11 months. It can range from 3 to 38 months. It lasts on the order of about 20 months. The ANC can be very low, 0, or it can be 500. The diagnosis is made sometimes by finding this anti-neutrophil antibody, though that's not always necessary. It's seeing that we have a normal marrow and that we're making the precursors to the neutrophils, but we're just not getting the neutrophils in our peripheral smear. We treat infections, we counsel parents, we rarely give GCSF, and most of what we do is reassure them. And after a couple normal ANCs in a row, we send them home from our clinic and tell them they don't have to follow up again. Okay. A 14-year-old girl develops fever, sore throat, and enlarged cervical lymph nodes. Her peripheral smear is shown on the next slide. Okay. So that's her peripheral smear. Why? I'm a nerd, okay, and it's a little more pathology, than you probably want to know. But why doesn't she have leukemia? Cytoplasm. I like it. One word, cytoplasm, right? Blasts, not often, think back to the oncology part. What you gotta see to know leukemia is you have to see big cells, big nuclei, almost no cytoplasm, and lots of monotony. As one of my favorite pathologists likes to say, the marrow of a patient with leukemia looks like a picture of a private school, okay? They're all wearing the same uniform, okay? You get it? I mean, they all look the same. Where you look at a normal marrow, it looks like the public school kids. They're all dressed differently, okay? So what you would see on this kind of smear is you see these big, you can tell these aren't blasts because they're big reactive lymphocytes with loads of cytoplasm. But what also clue you in, if I had shown a better picture, would be that you'd probably see some normal lymphocytes as well. Okay. So what's our most likely diagnosis? Big cervical nodes, reactive lymphocytes. Okay, I was too quick, I know. But the quick people are pretty sharp. Okay. I didn't give time for any of the wise guys to throw in something they didn't like. And so she probably has mononucleosis or EBV, okay? And again, what you want to learn there is to look just what does a reactive lymphocyte look like. Again, something that could show up in your picture book. Okay. What causes reactive lymphocytosis? Well, infections. They can be EBV, CMV, adeno, really anything. I'm sure this has been beaten into your brains in the infectious disease portion, but you can get reactive lymphocytes and profound lymphocytosis with certain bacterial infections, and the classic is pertussis. Reactive lymphocytes can also show up in just about anything, post-trauma, post-splenectomy, autoimmune conditions, and some premalignant states. Okay. So we're going to move on to bleeding and clotting, platelets and factors. Okay. 2 weeks after a viral syndrome, a 3-year-old child develops bruising, generalized petechiae, and gum bleeding. On exam, there's no hepatosplenomegaly, lymph node enlargement. Laboratory testing shows the patient to have a normal hemoglobin, white blood cell count, and differential. The platelet count is 3,000. What is the most likely diagnosis? Does this child have leukemia? Answer me. No. Because for the sake of your testing, one cell line, first of all, this child doesn't have leukemia. We're going to tell you a lot of reasons why. But one cell line down is not going to be leukemia. Does this child have severe aplastic anemia? Does he have TTP? Does he have ITP? Yeah. Does he have hemophilia? I don't think so. Okay, so go ahead and vote. And you better vote for ITP. Okay. Yep, they're my friends from Baylor right there. These are the guys who I had as residents. Okay. All right. So this is ITP. And again, I know I've said it many times, but I really believe it. And that is creating a mental picture. It helps you in diagnosis, and it helps you it helps you take care of the patients in front of you, and it helps you answer the questions on the paper in front of you. And so ITP is the well-appearing patient, okay? On rounds, we always go to the ITP patient's bed, and we say, look at that child bouncing up and down on the bed with a platelet count of 3,000, making me nervous, okay? All right? The leukemia patient who is thrombocytopenic is not bouncing up and down on the bed. They're in pain, and they look like hell, okay? So your mental image of ITP is the well-appearing child. Your test-taking image of ITP is a profound, isolated thrombocytopenia. Okay. So ITP is immune-mediated thrombocytopenia. I think we used to call it immune thrombocytopenia purpura, but its new official name is immune-mediated thrombocytopenia. It's destruction of antibody-coated platelets. The physical exam is usually normal except for petechia, bruising, gum bleeding. Lab features: isolated thrombocytopenia, isolated thrombocytopenia. And the MPV, what does MPV stand for? Mean platelet volume is going to be high. So, if you see something like 11 or 12, those are large young platelets. It's usually a diagnosis of exclusion. We don't have to, send off some test for. It's a clinical diagnosis, okay? I mean, you make this clinically. You don't send some test for platelet antibodies or anything like that, and you don't do a bone marrow, okay? Not with one cell line down, not with a good cause. Your management can be steroids, IVIG, Winrow. We can do platelet transfusion for life-threatening bleeding, or you know what else we can do? If this patient isn't bleeding, we can just observe him, okay? All right. Steroids, IVIG, Winrow, they all work. If you have life-threatening bleeding, you're going to do IVIG, and you're going to give platelets, and you're going to start steroids, and you're going to give whatever you can get the fastest, okay? What are some of the side effects of IVIG? Aseptic meningitis. I like to think of it as headache. You give somebody IVIG for ITP, go ahead and order their CT scan the next day. I'm being silly, but now in our hospital we've taken to sending them home with Benadryl and Tylenol to try to reduce the amount of post-IVIG aseptic meningitis headaches that we get and reduce the number of CTs, normal CTs that we're getting for these children, because it's challenging. Okay. All right. 2-year-old child is in septic shock in the ICU. Multiple blanching purple lesions of various sizes on his trunk and extremities. He's having oozing from an IV site. Okay. So what's going on? What's going on? Septic shock, bleeding, DIC, right. So this question is about what's true about DIC. So which of these is not true? D-dimers will be elevated, platelet count will be decreased, fibrinogen will be decreased, factors 5 and 8 will be elevated, PTT will be prolonged. Okay? So let's go ahead and cast our votes. Good. So D-dimers, always elevated. You know, you're just chewing things up. You're making clots, breaking them down. So D-dimers are going to be elevated. Your platelet count is going to be decreased. You're chewing things up. DIC, disseminated intravascular coagulopathy, right? So it's going to be, everything's all messed up. Fibrinogen, getting used up. If fibrinogen is elevated, it ain't DIC. Factors 5 and 8 will be elevated? No, they're going to be being consumed. PTT, you bet it's going to be prolonged because you don't have your factors. So DIC, disseminated intravascular coagulation, characterized by both bleeding and clotting. And you've had this beaten in your head since medical school, right? How do you manage it? Treat the underlying disorder, okay? Its lab features are what we just talked about in that question. Decreased platelets, prolonged PTP, decreased fibrinogen, not going to be elevated. Elevated D-dimers and fibrin split products. Our lab doesn't do fibrin split products anymore. But I don't know if yours does or whether, more importantly, the board exam question does. And it will have decreased clotting factors because they're going to be getting chewed up right and left. Okay. I'm not sure I like, you know, this. I wrote this question and then I was like, yeah, you know, maybe I'm not crazy about my answer. But I want you to channel your inner Willie Sutton on this, okay? All right, let's go back to Willie Sutton. 1-week-old male infant presents to the emergency room with continuous oozing from circumcision. Exam shows bleeding from the circumcision site. Hemoglobin is 7.9. Maybe we'll make it even lower. Let's drop that to 6.9. And the remainder of the CBC is normal. What is the next test to check? Von Willebrand panel, antiplatelet antibody test. Hint, that's always worthless. DIC panel, PT, PTT, INR, factor 8 level. So go ahead and cast your vote. If somebody votes for that antiplatelet antibody test, game on, exactly. All right, thank you. You know, I'm really pleased. Bleeding like this from a circumcision is going to be the story for hemophilia, okay? And that's what I want you to remember. And you might be sitting there, well, listen, knucklehead, if they're hemophilia, if they got hemophilia, isn't their PTT going to be prolonged, and wouldn't that be a good test? Well, yeah, I'd probably order it, but the thing is, on exams, you usually only get one test, right? You get one right answer, and they usually want something that's going to be more specific or more diagnostic. So what are PTT norms in 1-week-olds? They're like all over the place, right? You know, and preemies, you know, all kinds of stuff. Your stuff can be way out of whack. But if you're suspicious of hemophilia and you want to diagnose it, what is the factor 8 level going to be if this child has hemophilia? It's not going to be something that's going to be subtly off or off a little bit because he's a newborn. He's going to have a factor 8 level of 1% or something like that, okay? So again, what I want you to think about from this question is, think about the presentation of hemophilia, but also think about what test is going to give you the specific answer. And, you know, if there's factor 8 and factor 9, I don't know. You know, factor 8, hemophilia A is much more common than hemophilia B. You know, it's just going for factor VIII makes sense here. So hemophilia can be a deficiency of any of 3 clotting factors, 8, 9, and 11. There's hemophilia A, B, and C. And it can be mild, moderate, severe, post-circumcision bleeding, epistaxis, soft tissue bleed, okay, post-traumatic surgical bleeding, intracranial bleeding. Please think of muscle hematomas, soft tissue bleeding, joint bleeding, okay? This is how these kids will present, with joint bleeding, okay? That's a real big one. Yes, the PTT can be prolonged, and, so I do understand if you're not happy with that last question. But again, PTTs are going to be prolonged in newborns. And yes, you can compare them to the newborn range, but the money is going to be where the factor level is. How do you manage these? Factor replacement, education, physical therapy, prevention, and now prophylaxis. Let me make a plug for hemophilia treatment. I have a mentor at Baylor, a guy by the name of Don Mahoney, who I consider to be the best clinician that I know, one of the smartest guys. And what he talks about with hemophilia, and this will be important for patients, but also important for exams, is that when you have a hemophiliac with a problem, you treat first and think second, okay? So if you have a patient with hemophilia who comes in with some sort of trauma, a head trauma, a big joint, you give them factor, you correct their coagulopathy, you correct their bleeding disorder, and then you think. In a good hemophilia center, the time from arrival to the door with your problem to factor administration should be less than 45 minutes. Faster if possible. And if you're working in an ER, and that patient brings you their factor from home, give it. Okay? All right? So again, what do? Fix it first, think second. Education, physical therapy are all really good. A good hemophilia clinic is a multidisciplinary clinic where patients are not only seen by their hematologists but are seen by physical therapists. The more that we can do to prevent joint destruction, the better their quality of life is going to be. Prophylaxis, a lot of different schedules. Every other day, prophylaxis is really common. What can throw hemophilia into, what can kind of make hemophilia more challenging to treat? Inhibitors, right? Okay. So what do you give a hemophilia patient who has, is undergoing surgery or something that has an inhibitor? What choices do you have? Yeah, Nova 7, whatever you want to call it, factor 7A. You can, in some circumstances, just give them overwhelming doses of factor replacement to try to correct that. Okay. Question number 13. 12-year-old girl presents to the ER with pallor and fatigue. She has just reached menarche and has been bleeding for 7 days. CBC shows a hemoglobin of 6.7 with other counts normal. Okay. What is the diamond here? Okay. Just reached menarche. Okay. All right. So what diagnosis does she have, and which of the tests are going to be, which of the following is going to be true? Factor VIII less than 5%, INR greater than 3, lupus anticoagulant positive, von Willebrand less than 30% of normal, antiplatelet antibody testing. Don't you dare order that. Will be positive. All right. Okay. Okay, I knew there had to be a wise guy or two ordering their antiplatelet antibody testing. Okay, so really, what is this the picture of? Von Willebrand's disease, okay? And, classic story, prolonged menarche, prolonged bleeding, just happened. We have a whole clinic, in our system where we see young women get seen by both the OB-GYN and their hematologist. And the most common diagnosis they make is von Willebrand's disease. And that's going to be characterized in many cases by having a factor level less than 30%. Von Willebrand's disease, when you get beyond type 1 von Willebrand's disease, I think it's really confusing. So all I'm going to focus on is type 1 von Willebrand's disease. Von Willebrand's disease is the most common bleeding disorder. I am quite certain that there are many of us here that have some form of von Willebrand's. It's type 1 is by far the most common, and it's characterized by decreased levels of von Willebrand factor. It can be treated with DDAVP. So where is von Willebrand factor held? It's in the endothelial cells, right? On the Weibel-Palade bodies, in the Weibel-Palade. I love that word. I just had to work it in. I'm sorry. So, but and it's carried around with factor 8. So sometimes patients with VWD can have very mild prolongation of their PTT as well. There are many other types of VWD, and they typically involve some qualitative defects in the von Willebrand factor or an absence of these big multimers. So infant hematology. I hope there'll be some overlap. I hope the neonatal lectures that you get in the next coming days will overlap this a little bit. But there are a couple things that I did want to cover here as well. This is a classic question. It shows up on the heme boards. It shows up on the peds boards. You better know this. The term infant who was delivered at home. Okay? All right, we can almost stop reading at that point. Okay? Now has blood in stool. Okay? The grandmother finding a mass and the term infant born at home are always going to have problems. I think the board doesn't like home births. And they don't like grandmothers apparently either. On exam, there are no petechiae, purpura, hepatosplenomegaly, or neurologic abnormalities. Which of the following is the most likely diagnosis? Okay, DIC, neonatal alloimmune thrombocytopenia, congenital CMV infection, vitamin K deficiency, or hemophilia. Okay? Okay. I'm sure the midwives, the nurse midwives hate this question, because somebody who does home births is probably going to make sure they give vitamin K. Vitamin K always gets given in the nursery. And so this patient who was born at home is your classic story for someone with vitamin K deficiency. And so vitamin K deficiency is a deficiency of the clotting factors 2, 7, 9, and 10. If you want to know the vitamin K dependent clotting factors, I always think of 1972. I was alive then. You probably weren't, so I don't know if that'll help. But 1972 gives me 10 and 9 and 7 and 2. You get this hemorrhagic disease of the newborn. It can also happen with malabsorption and chronic diarrhea. Patients with cystic fibrosis get it, and certain drugs, and as mentioned in the infectious disease lecture, can also lead to vitamin K deficiency. Prolonged PT and PTT. It's not going to be an isolated prolonged PTT. Think about what you've seen in your vitamin K deficient patients in the units. I mean, everybody gets a little bit vitamin K deficient when they've been really sick, been on antibiotics. When you correct vitamin K, you're usually seeing some kind of prolongation in the PT, not just the PTT. Management is vitamin K, or if you really need to get the factors quickly, you give FFP. What doesn't FFP contain? I always think of it as fibrinogen. It doesn't contain fibrinogen. And so to correct, if you have hypofibrinogen, you need to give cryo. Okay. All right. So we have a 3-day-old infant who presents to the ER with hypertonia, arching in the back, and a high-pitched cry, and also lethargic. His lab results show that his bilirubin is 28.7. I saw this. This was heartbreaking. And this happened because this patient got sent to, this is when I was training, and this got sent to us. I'm a complete inbred. I did all my training at TCH. Maybe that accounts for some of my issues. But this patient had been seen at a very small outside hospital, and the family had been taken care of by English speakers without a significant intervention to get a translator for them. They spoke Spanish. And when, eventually the history came out that Dad both had a history of anemia, and he'd pulled up his shirt to show us his scar, and that he'd had a surgery. So he'd had a splenectomy. So what's this patient got going on? Okay, and what are you going to see in their brain? Yeah, you're going to see bilirubin deposits, right? It's just horrible. So what caused this child's underlying condition? A maternal infant ABO incompatibility, sickle cell disease, congenital CMV infection, hereditary spherocytosis, neonatal alloimmune thrombocytopenia. So, yeah, it's not going to be maternal ABO incompatibility. I think the clinicians, the people here who are recertifying, will tell you that they've probably never, they've never seen a bilirubin of 28 or 30 or something like that with maternal ABO incompatibility. So it can't be that. It's not going to be sickle disease. Congenital CMV infections, you are going to have hyperbilirubinemia. You are going to have, lots of different problems, but you're not going to have bilirubins to that level. This is hereditary spherocytosis, and I think, when I did my continuity clinic, I learned from, I had the pleasure of training with a fellow who had been in private practice for about 35 years, and he always swore up and down that the worst hyperbilly babies he had were the ones who had a family history of hereditary spherocytosis. And you had to try to catch that in a good history. So hereditary spherocytosis is an autosomal dominant inheritance pattern. It is an important, serious cause of neonatal jaundice. You're going to see spherocytes, increased osmotic fragility. It's a hemolytic anemia, right? Cells are dying, so the bone marrow is going to respond, and you're going to have a reticulocytosis. And it's going to be managed by transfusion where needed. And if you have continued problems, it's managed by splenectomy. You've been a very attentive audience, and I'm really grateful for that. And I hope the heme and the onc go very well for you. And good luck. Knock 'em dead.